So the topic is pregnancy on the kidney. I kind of all these 5 things.
Yeah.
Renal changes in normal pregnancy, CKD in pregnancy, AKI in pregnancy, hypertension in pregnancy, and pregnancy in patients on dialysis. I kind of put in like all these points more like as high yield points. So things you kind of can go back and look and kind of have a quick review. I initially just wanted to do like a PowerPoint, like, just like on the board, but I thought it was better because then you could actually go back to look at it. I would like to face you guys. Okay. So yeah. So I'm going to first go normal physiology. So for the kidney size, you are going to have a enlargement, usually typically by 1 centimeter on your diagnostic test, like an ultrasound, and it returns to normal postpartum. There is some urethral dilatation, which is mostly related to the hormones, and typically you see more right-sided hydronephrosis than left. This could be confused with obstructive uropathy. I'll go a little bit in depth as to how to differentiate between hydronephrosis related to like just normal pregnancy versus having obstructive uropathy. But that could be a normal finding in pregnant patients. Kidney function, your GFR and renal plasma flow increases by 50%. So this leads to a decrease in serum creatinine. So any creatinine above 0.8 is considered abnormal in these patients. And you do see protein and glucose excretion increased. So you could have glucosuria. So if you check a urine dipstick, you could have positive glucose. But in pregnant patients, that is not a good test to check for diabetes. Almost 50% of the patients can have, pregnant patients can have positive glucose on the dipstick. And it is just because of the increased filtration of the glucose. Acid-base balance, this we all know, right? Hyperventilation and respiratory alkalosis happens, and then this results in increased renal bicarbonate excretion. So your bicarb levels could be a little low, and usually typically around 22. I've seen all the way to 18, but I would say 18 to 22 is typically what you would see. Anything below 18, I would be like, okay, there might be another cause. And you would see the pH still being kind of on the higher end of normal range. Plasma osmolality, so you will have a decrease in serum osmolality by 10 points, and you will have the serum sodium lowered by 5. So if you have a serum sodium above 130, then that's kind of within normal limits. You could have all the way to 130 during pregnancy. You also can have a transient DI in these patients due to increased plasma metabolism of ADP, but this is transient. It does get resolved. So those are other things to kind of know what happens to kidneys when you are pregnant is you will have an increase in cardiac output, there is a fall in vascular resistance and blood pressure, and there is blood volume expansion. So these are the systemic hemodynamics which happen when you're pregnant. So, a lot of things which happen during pregnancy is because of these alterations in your hemodynamics. You have like decreased vascular resistance, so you have a lower blood pressure, you have increased cardiac output, and you have a plasma expansion. So all of this kind of hyperdynamic circulation, right? So, for patients who have heart failure, pregnancy is going to be a stress on them. So that's something you kind of want to remember when you're thinking of all the patients who have, kidney disease and are pregnant. How do we estimate GFR in these patients? This is one place where you want to do a 24-hour urine collection to calculate the GFR. The eGFR formulas, the MDRD, and the CKD EPI. So the CKD EPI, they did not have pregnant patients when they had the study done, when they developed the equation, and then the MDRD does not correlate with the creatinine clearance. So 24-hour urine collection, and then Also make sure you're doing the urine creatinine because when you do, the reason why we don't do 24-hour urine collection for creatinine clearance is mostly because they're either under collecting or over collecting or, so you want to make sure you're doing your urine creatinine and then it should be 15 to 20 milligram of creatinine per kilogram of body weight, the current body weight, not pre-partum before conception. It should be when you are checking your GFR, that's how much your urine creatinine should be to get an accurate GFR in these patients. Cystatin C levels also don't help because during pregnancy, the cystatin C levels go up. So we would go all the way in first trimester from 0.9 to second trimester, I think 1.2 to 1.6 all the way in the trimester. So that is not going to help you with your GFR. So you need to do a GFR weight collection to get your creatinine clearance. So the other lab abnormalities, the same ones we discussed, you can have hyponatremia, you can have proteinuria, typically between 150 to 250, not more than that. If you have more than 300, that's definitely abnormal. Glucosuria, again, in 50% of pregnant patients. Hypoglycemia, this one, you start off low, and then as you go into a second and third trimester, it kind of returns to normal levels. You do have decrease in albumin, and that, of course, affects your anion gap, so that is going to be a little lower. So maybe 8 of anion gap is what you would typically see, and then probably a little lower on the albumin, maybe less than 4, like 3.5.
Why does the statin C level go up when creatinine is going down? The statin C, my understanding is it is made by nucleated cells, right? Yes, they are pregnant, so they have a little bit more nucleated cells than before, right? But still rising in the third trimester.
Yeah. So I don't know the reasoning behind it, but yes, so you can't use the statin C because
Dr. Sowmya. Dr. Sowmya.
Yeah. Yes.
I think it could be because cystatin C is from the nucleus, right? Maybe because of the babies, cystatin C might be actually secreted, I'm thinking, because there are more cells in the third trimester.
Yeah, Dr.
I mean, it might be like increased fraction, but you would say like increased fraction from creatinine. I don't know, I don't exactly, but that could be right, so I don't exactly know why the cystatin C levels, but it's just rise during pregnancy, but it's just not helpful for your GFR. Okay, so moving forward.
So, I'm so sorry, just interesting conversation here. So if somebody has twins, their cystatin should rise even more.
Right.
Right? If that's the case, if it is just the features contributing to it. I got interesting questions, I guess we'll have
Yeah. Yeah. So, okay. So, and then, so this is pretty much the normal renal changes in pregnancy and what you would kind of, see which are variations and just to be aware of. So now we're going to go CKD and pregnancy. So the way the pregnancy, CKD affects pregnancy, right? And then how the pregnancy affects CKD, right? So there are 2 ways to look at it, right? So what are the effects of CKD on pregnancy? What are the outcomes, maternal and fetal outcomes with patients who have decreased GFR? One, you're going to be at higher risk for preeclampsia and gestational hypertension. You will have higher risk of premature birth. This is in addition to also someone who has hypertension and proteinuria. So those are also dependent risk factors. Small gestational age, higher C-sections, and then pregnancy failure. Especially when the hypertension is uncontrolled, you can have pregnancy failure. So all these risk factors, CKD can cause pregnancy. What about pregnancy on CKD, right? So as nephrologists, that's what we are worried about, right? Like, what is this pregnancy? Like, don't get pregnant. That's what I'm telling my patients. No, I'm not. But I'm just saying, like, CKD in general, we don't want anything to make things worse, right, for our patients. But definitely pregnancy is one thing which could affect your CKD. So patients who have CKD stages 3 to 5 lose, like 46% of them lose 25% of their kidney function, or at require kidney replacement therapy by 1 year postpartum. That's like a big drop, that's like a big, risk which they are taking when you have a CKD stage 3, 4, 5 patient who is, going to be, getting pregnant. So an average loss of eGFR was noted to be around 4.5. Proteinuria of more than 1 gram is associated with higher risk. And then you also have uncontrolled hypertension, and then, because, they're pregnant now, you have gestational hypertension, you have high risk for preeclampsia, and now they're kind of interrelated. This doesn't help that, and that doesn't help this. And then, of course, the last thing, potential flare of underlying disease, right? This is what we are worried in our patients who have lupus, nephritis, and want to get pregnant. That's the most common scenario which we come across. So we're going to go about how are we going to manage these patients. So it's really important, right? You have a CKD patient who is in childbearing age and is just telling you, oh, I want to get pregnant, So now you kind of want to counsel them. You want to tell them, hey, you're taking a risk. This is going to be your risk, and you also want to make sure that when they get pregnant, they are in the best shape, right? They have minimal proteinuria, their blood pressure is controlled, because that's going to help with good outcomes. And you want to make sure whatever the underlying cause for kidney disease is well treated. And most of our data for patients on pregnancy comes from transplant patients. We don't have much studies on patients who just are CKD and got pregnant. We have more data, and all of our knowledge is from patients who are transplant recipients and they have gotten pregnant because they're more closely monitored and kind of, are following them and knowing where they are and how they're doing. So what do we do? Of course, as we discussed, we're going to try our best to, make sure the blood pressure is controlled. If they are on ACE inhibitors or ARBs, so the guidelines are stop at conception, right? Because you might have a diabetic patient who has chronic kidney disease. It might take forever for them to get pregnant, right? So you don't want to just stop ACE inhibitors the moment they tell you, I'm going to want to get pregnant, because you want to wait, especially if you don't have any other agents to help with their proteinuria, to keep the ACE inhibitors going, and then the moment you know that they're, they're conceived, then stop the ACE inhibitors. The one thing to remember there is, if you have a patient who has been having regular menstrual cycles and, you know that their chance of getting pregnant is high, then you probably want to stop. So it's kind of very individual based, but you can stop at conception. You can say, like, hey, the moment just stop the ACE inhibitors. When do we start it back? We can start right after birth because it doesn't get into the breast milk. So the ACE inhibitors, the 3 medications which have been studied, captopril, enalapril, and quinapril, can be started right after childbirth. ARBs with very limited data, so avoid them. So we want to do ACE inhibitors. SGLT2 inhibitors, these are something which we are very commonly prescribing, especially for our diabetics who have kidney disease and proteinuria. We want them to stop. Like the moment they tell you they're thinking of getting pregnant, stop them. Because animal studies have shown that they affect kidney development. So it's definitely a no for this medication. Diuretics can be safely used. Typically in first trimester, you really don't want to give them, if they were on diuretics, you kind of want to make them as needed. You kind of want to really go by day rather than prescribe them at a dose and then get into trouble. Immunosuppressive medication. So most of our patients, right, they are on steroids, they are on hydroxychloroquine, they are on Cellcept, they are on tacrolimus, cyclosporin. These are the most common immunosuppressive medications. The good thing for transplant recipients, it is safe for them to use the tacrolimus, it is safe for them to use the cyclosporin, it is safe for them to use the steroids. And for our lupus patients, most of them who are on Cellcept, you change them to azathioprine, you do want a washout period of 6 weeks for Cellcept. So once they plan on pregnancy, you want them to stop the Cellcept at least 6 weeks before that. Same thing with leflunomide as well. You want to stop them. You want a washout period for it, like for patients who have rheumatoid arthritis. You, of course, have to follow the levels very closely, especially the postpartum period for the tacrolimus and the cyclosporin, because there could be a lot of variation, and then you want to adjust the dosage accordingly. Rituximab is also not recommended during pregnancy. Like most of those newer agents, they're not recommended, and we don't use cyclophosphamide either. So steroids, azathioprine, hydroxychloroquine for all lupus patients, these are a choice. When we do a kidney biopsy, so let's say we have a patient with, who has had worsening renal function, and you kind of want to know what's causing the rise in creatinine. Second trimester is considered the best time to do a kidney biopsy, and you also kind of want to make sure, like, you're gonna be changing your management based off of that kidney biopsy. You don't want to just do a kidney biopsy for diagnosis. You really want to know if you really want to do it, if you know, like, this is gonna warrant change in management for the patient. Okay, so how do you prevent preeclampsia? Low-dose aspirin has been well studied in patients who are not have CKD in high-risk obstetric patients, and it's well tolerated. So you can definitely prescribe that to your patients to decrease their risk for preeclampsia. Vaginal delivery is preferred. Some of these are just like the usual things which you would recommend anyway. When do you do preterm intervention? When do you recommend, like C-section or delivery? Is if you have severe preeclampsia, if there is fetal growth restriction, or if there is like fetal distress, which is pretty much the same for any obstetric patient, right? Like, those would trigger you to do some intervention. The other time, from nephrology standpoint, is if you have had like a significant worsening of your renal function, then that could be a reason also to, intervene, once the fetus is viable, and, make sure that, you can take care of the neonate postpartum. So a lot of these patients who have preeclampsia are getting magnesium sulfate, right, as part of their, seizure prophylaxis and treatment for preeclampsia. Patients whose GFR is less than 30, just don't follow the protocols, be very cautious. I've had patients with PAC levels all the way up to 12, 10 when they have CKD or they develop AKI, so be cautious. But it's still used, it's just not, you just have to keep following the PAC levels. Make sure you're not doing MAC toxicity in these patients. So hypertension is quite common, right? So, the goal blood pressure is between 120, 70 to 140, 90. Nifedipine or any other calcium channel blocker is safe during pregnancy. So is labetalol and methyldopa. I don't use methyldopa. I mostly just use nifedipine and labetalol, and most of my patients have never had any problem controlling their blood pressure, as long as we could easily, safely administer one of these medications, and they are able to control their blood pressure quite well. So if they do have CKD like stage 4, and then you have problems with hypophosphatemia, which you don't see, you just recommend a low phosphorus diet. But if you do have to give a binder, then TUNS is what is recommended. The other binders have not been studied, so we are not sure if they're safe during pregnancy. Calcitriol can also be used in these patients. For anemia, IV iron can be utilized, so it's PO iron, and then ESAs, due to a huge, large molecular weight, they don't cross the placenta, so you can use the ESAs also safely, whether it's a CKD patient or dialysis patient. So typically we do dialysis, right, based on whether they're having uremic symptoms, or if they're having hypokalemia, fluid overload, or something else. But this is one place where we would initiate dialysis in a patient whose GFR is less than 20 and whose BUN is about 50 to 60. So if you have those, you can initiate dialysis. Catheters are fine, like these patients do fine with dialysis catheters because you're going to be doing intense dialysis. So fistulas can be utilized as well, but placing a dialysis catheter and doing dialysis is what's recommended if the GFR goes below 20. So
You do dialysis every day, actually.
So yeah, I'm going to come to that, but yes, you want to do like more than 36 hours in a week. I'll come to what I do. So we'll go over that. I'm going to talk on dialysis.
How would you estimate the GFR again? Like,
So 24-hour urine collection.
So you have to
Yes, you have to do 24-hour urine collection because the eGFRs have not been studied in pregnant patients, and then the cystatin C doesn't work. So that is how you do. So you
Okay,
check,
so you
you
just
think
look
any
at
stage 4 patients, yeah.
And you would have to like preemptively just start.
So if you see that if the catheters is below 20, then you would go ahead and place a tunnel dialysis catheter and start dialysis on these patients. Yeah.
But the last point in dialysis on GFR below 20, even if there is no clinical indication.
Right. That is the clinical indication. Yeah, because the fetus doesn't do well with the uremia.
Even like, okay, no symptoms, still make urine, everything is fixed, still goes on.
If you have all those, you would definitely start dialysis. But even if you just have these, that's enough to, do that. Okay. Okay, contraception. So this is important, right? So if you have a young patient, you discuss contraception, they might ask you what should I use. So it's pretty much the same as in, a patient who doesn't have kidney disease, right? So the long-acting reversible contraceptives like IUDs are the best because, those, they're very quickly reversible and, when they do want to get pregnant, they can. And, like the Celsep, these are, medications that you don't want to are inhibitors, like all these medications they're on, IUDs is probably the best and also most effective, like, less than 1% chance of contraception failure. So you want to use that. So the depot is the next best thing, so yeah, especially if they're having a lot of bleeding issues and, the IUDs are not, working for them, the depot is probably the next best option. Also on IUDs, there's no increased risk of infection or clots with IUDs, in our patients. And the third option is the OCPs. Progestin only pills, it's like you have to take the same time of the day, it's just harder to take, but probably a good option. Combined hormonal pills, with the estrogen, you have gas activation, so you have a higher risk of thrombovascular events, hypertension, and also proteinuria in our patients. The transdermal patch also increased risk of thrombovascular events, but not the hypertension, the patch. But with the OCPs, the combined pills, you have problems with hypertension and proteinuria as well. The IUDs with the estrogen, they also don't increase your risk for cardiovascular events, so they're like local, so you can use them. Okay.
So the OCPs or the combined one, it's not an indication, like we don't give, or do we give them as an option?
That's an option, yes, but you just need to know that they have an increased risk associated with hypertension, proteinuria, and also with increased cardiovascular events. Yeah.
It's the same as for pregnant, like for women, like one's contraception, right? Those are like general issues with the OCPs, right? They're like
Yes, yeah. Even if they don't have CKD,
That's
you're
right.
right. So any patient, yeah. But in our patients, it's a higher risk, especially if they have autoimmune condition, they have a higher risk for, thrombosis and thrombovascular events. Yeah, so IUDs are probably the best, So we move to AKI in pregnancy. So, like the common ones, we're gonna start volume depletion, right, in the first trimester, especially when they have hyperemesis. So usually you give fluids, that should help, and that's probably the number one thing you would think of someone who's coming in with AKI in first trimester. You could have infection leading to AKI, like in any other patient who doesn't have CKD. It could be sepsis unrelated to pregnancy, such like abortion, or like, someone who has acute pyelonephritis. It should happen in any patient. Or, the worst ones are, of course, ischemic ATN, or if you have renal arterial necrosis. The ischemic ATN in the setting of having a massive hemorrhage, whether it's postpartum or like a rupture of placenta, or amniotic fluid embolism, or if there is like a prolonged intrauterine death. I have seen in this hospital amniotic fluid embolism. I have not seen massive hemorrhage causing ischemic ATN, but I've seen definitely a lot of ATNs postpartum here. One case of amniotic fluid embolism. So, really, on all these patients, you're going to see AKI. The other important thing is the microangiopathic hemolysis and thrombocytopenia. So I'm going to go over all of those like in a table form, but that's something you also are thinking of in patients who have AKI during pregnancy. And then the nephritic syndrome, right? Especially if you have AKI in the first trimester or below 20 weeks of pregnancy, you should be thinking of a glomerular cause, lupus or ANCA. So with preeclampsia, you're going to have a bland urine. Right, so you're not going to have inflammatory cells, but you have proteinuria. But with nephritic syndrome, you are going to have inflammatory cells. So that is like a kind of a differentiation when you do a UA to kind of see, hey, is this, let's say they are about 20 weeks, then 22 weeks, and then now you're in either preeclampsia or something related to glomerular. So you kind of look at the UA, if it's bland, then maybe you can think it's more preeclampsia. So that's something we want to think of. And then kidney stones. I'm not going to go into detail of kidney stones, but the management is the same. It's just quite common. I think it's like 1 in 600, 3,000 pregnant patients. So, you would still do the stent placement and whatever treatment you would do for a patient, So these patients come in. So the way you differentiate with someone who has hydronephrosis just related to the urethral dilatation from normal pregnancy versus someone who has, some pathology causing the dilatation is, one, you will see they'll have flank pain. So if they're saying they're having flank pain, that goes more with some other cause other than just being pregnant, causing the hydronephrosis. And then the other thing is if you're finding something, usually typically ultrasound, a stone or something which is causing the blockage. So that's how you kind of differentiate. So if they don't have symptoms, you did an ultrasound and you have some, hydronephrosis, which you usually typically see more on the right side, that's okay. You don't have to do anything, just monitor those patients. So a little bit more on preeclampsia. So you kind of want to have a blood pressure above 140 or systolic above 140 or diastolic above 90 on at least 2 occasions, 4 hours apart. And this is after 20 weeks of gestation in a previously normal tensive patient. And you need to have one of the following. You see proteinuria of more than 300. Again, we do a 24-hour urine collection. If that is not available, you can use a urine dipstick of 2+, or like a random urine spot protein creatinine. You have done at least twice, to confirm that they do have more than 300 protein. Platelet count of less than 100,000. Serum creatinine of more than 1.1 or doubling of creatinine. LFTs at least twice the upper limit of normal at your lab. Pulmonary edema, new onset headache, or visual symptoms. So those are this is very important because, a lot of preeclampsia gets kind of in our, differential when we are taking care of patients with CKD or people who have developed AKI in their later second trimester or third trimester. So those are the, diagnostic criteria, so just to keep in the background. So you have a patient, so now, you have AKI, right? So these are the most common ones which you're kind of in your differential when you have a patient with abnormal lab findings and proteinuria. So preeclampsia, usual onset is third trimester. AKI severity is variable. You will have elevated LFTs, which is quite common. Acute liver failure, though, is uncommon. And then there is a spontaneous recovery after delivery. So typically after 2 to 3 days of delivery, you will see, there is recovery. You're really not doing anything, you're just kind of, doing supportive management for these patients. With TTP, it can happen, in second and third trimester. It's the same management. This is more managed by hematologists. It's the same thing. You can either have LMTS 13 deficiency, so these patients are at higher risk for developing TTP in their second and third trimester. The AKI severity is mild. So TTP, 2 organs, right? You have the thrombi developing in your brain or in your kidneys, right? So, neurological changes, and then you're having AKI, but it's usually typically mild. Elevated LFTs are uncommon. Liver failure again is rare, and then this one also does not recover after delivery. There's no improvement. Complement mediated TMA. This is very this is important for us because this one again does not recover after delivery, and then you have very severe AKI, and a lot of these patients end up needing kidney replacement therapy if they do develop. And this is in usually like late third trimester, close to delivery time, or immediately postpartum. And then the acute fatty liver, so that again is in third trimester, but you always have acute liver failure in these patients. And then they also spontaneously recover. So preeclampsia with severe features or the acute fatty liver, all you need to do is, just deliver, and then that should help. With the TTP and complement mediated, there's specific management needed.
There's a blood test for preeclampsia that SFLT PIG, have you heard of this?
Is it available?
That's what I was going to ask you. There's a
I'm not
soluble
sure.
FMS-like protein. I can Google, I guess. 5-10 years ago, there's a test that developed, the placenta secretes when it's trying to get more blood flow. So levels are shown to be high, but I don't think it was commercially available. But I thought maybe now it's commercially available. Because it helps us when we have patients with lupus or whatever, we're trying to decide if preeclampsia versus lupus flare or something else. That's always
Yeah, it's a 1:1 to plate ratio.
Yeah. Is have you ordered or do you know?
Never ordered it. That was when I was a fellow. That's when they were studying it actually.
Yeah, that's not that how it should be available.
Yeah.
It really for us, this would be very useful.
FSM like tyrosine kinase to placental growth factor.
Yeah. I'll check on Quest.
Okay. I've not used it. So preeclampsia, so urgent delivery, abnormals usually we need to resolve within 2 to 3 days. ATN and renal cortical necrosis. The cortical necrosis is associated with poorer prognosis. A lot of them end up needing long-term kidney replacement therapy. ATN typically recovers in 2 to 3 weeks. TTP, plasma exchange, if you have complement-mediated thrombotic microangiopathy, then anti-complement therapy with eculizumab. If you don't treat them, they're going to end up needing, dialysis on them. And then urgent delivery, the same as we have for fatty liver. Okay. So when you have hypertension in pregnancy, it could be.
I guess for complement-mediated diseases, you would not do plasma exchange in patient, right? That's going to be too much risk for the RH phenotype.
So low complement is what you will see in these patients. So this is the hypertension. So various differential patients who have hypertension. Let's start off with the chronic hypertension. So there are patients, they have high blood pressure even before pregnancy, right? And then most of them tend to have hypertension during pregnancy, and the proteinuria is variable. They don't have thrombocytopenia or they don't have elevated LMTs. Then is the gestational hypertension. Again, they were normotensive before, right? So they're not like a chronic hypertension patient. These patients just develop hypertension just during pregnancy. Again, they don't have proteinuria, they don't have thrombocytopenia or elevated LFTs. When it comes to preeclampsia, then you are going to see proteinuria, right? So that's one of the things you're going to see, and then you're going to see thrombocytopenia and abnormal dialysis. When you have preeclampsia superimposed on chronic hypertension, again, you will have proteinuria or thrombocytopenia. So that's kind of how you kind of differentiate between gestational hypertension and preeclampsia. A lot of times they are sending you, to the nephrologist, when they see a weighted blood pressure. Right, so pregnancy in patients on dialysis. So we have seen more patients, getting pregnant lately with all the advances we have had, both in maternal fetal care and also in terms of dialysis. So you have a higher incidence of pregnancy in nocturnal dialysis patients versus conventional in-center hemodialysis patients, much lower in peritoneal dialysis patients. So you ask them, so if you have a dialysis patient who is now pregnant, you want to ask them to increase their protein intake, 1.5 to 1.8 grams per kilogram per day. You want to double their vitamins. We usually just ask them to take twice daily. And then the folic acid is at 5 milligrams daily for these patients. You liberalize their dietary phosphate intake. Because they're doing daily dialysis, they're gonna, kind of be close to regular diet. Of course, if they have high blood pressure, or diabetic, you would do the heart healthy and diabetic diet. But otherwise, you try to be as close to as you would want to be to the diet without necessarily putting them on renal restrictions like low potassium or low phosphorus. You would use a 3K bath because you're going to be doing daily dialysis, and then Tums as a binder if needed. Most of them don't need it, they're okay with just diet. So usually what you would see is they gain 2 to 4 pounds in the first trimester, and then afterwards you will see them gain 1 pound every week. So you also can prescribe the low-dose aspirin as you would do in CKD patients to prevent preeclampsia. So intensive hemodialysis, more than 36 hours. So how many hours do you do on your patients?
I've only had a couple.
Yeah. I have not come to 36 hours, unless they are in the hospital and have done long, everyday dialysis, because 4 hours, 7 days is 28.
20 hours.
5 hours has some change.
Yes, yeah. So the thing is, they want 6 hours, 6 times a week, right? So the 36-hour prescription is.
Is that new change? I thought 20 hours was the old one.
No, 36 hours. So 6 hours, 6 days is what, we would do, to kind of help them, the maximum. But, it's really hard on the patients. They kind of really struggle to stay on the machine that long. So we, typically, all of the patients who have gotten pregnant and have gone beyond 24 weeks have been admitted to the hospital. And most of the time they are getting their care in the hospital, so they are able to do that longer hours. But what I have done is, try to do at least 4.5 hours, 6 times a week, until 24, 26 weeks, until they usually by then they have other complications, something. Yeah, so UTMB and gas assurance, so we have worked very closely with both. We've had some patients who have gone all the way up to 28 weeks. So then we kind of whenever they're going to their healthcare medicine, we make sure we get their notes and we send our notes so they can kind of look at everything. So yeah, but not everybody gets admitted, so you kind of.
We had a couple of patients in the dialysis, but we managed till 26, 28 weeks and then transferred to care to downtown hospital.
Yeah, usually they end up being admitted for one or the
Yeah, that's
other
why I
reason.
want to see them. When I was a Baylor, I worked with brilliant. That was
Yes.
one of my grounding areas. So I was around, when I was there, I was around on this patient. I had like 4 or 5, I mean, not a lot, maybe it's not super common, but
Yeah.
36 still seems like a common, and I remember doing.
Yeah, but that is what is recommended. They want more than 36 hours. Avoid intradialytic hypotension, and then weekly assessment of volume status. And then one thing to remember, heparin safe, which we all know because we've had patients with ABG who are pregnant and we've given them heparin, but it's kind of safe to give during dialysis if they need it. Again,
Sure.
I have not had a patient on peritoneal dialysis who is pregnant.
No, usually hemodialysis is preferred rather than peritoneal dialysis.
No, yes, so but
Complications are more in the peritoneal.
I thought just the face, like you don't have
Yeah.
as much.
so you kind of keep going down on your exchange volume. Apparently, that is what they're saying. 20 exchanges of 750 ml over 18 hours. So you're pretty much doing one exchange every hour. So it's like continuously doing exchanges throughout the day, which is going to be very tough, especially when it comes to trimester. So I haven't had any patients, so I have not done it. But I would think like hemodialysis is probably, and yeah, go ahead.
Yeah, the discharge is the hemodialysis.
Yeah. And then a lot of social and emotional support, these patients, not just the ones, who have had, successful pregnancies, also the ones who have had miscarriages, so you kind of have to make sure that they're getting the support they need, which we all kind of learn as we go. We don't see that when we start our pregnancy, but then we only realize once we start practicing, oh God, all of this is also kind of needed, for them in terms of support. So you kind of start off early. Once hey, you kind of get the social worker support and all the family support early on because as the pregnancy goes, they're gonna need extra support.
So the PD patient gets pregnant, then you would put them on chemo?
Yes, if I had a PD patient who gets pregnant, I think that is what I would recommend. This is our most recent baby. This picture was actually taken this past week. So she was a home hemodialysis. She is a home hemodialysis patient. So she did 6 times all by herself at home, and she delivered the baby in November. Baby stayed in NICU until February. So she brought the baby in March. So that was the whole team. Happy that we had a successful, pregnancy. So it's very fulfilling, I think, when you have a patient who wants to be pregnant and has a good outcome because a lot of times they don't. So it's good. So you can do this whether it's home hemo or in center. We do want to provide respite care if they want, for the home hemo patients, so that way they get a break from doing everything all by themselves. Yeah.
How old is she?
She's 40s.
Yeah.
She's old. So she was high risk even, and this is not her first polio. I mean, in the sense she had another, pregnancy during, being a home hemo patient, and then we lost that, and then this was so this was like a very, this was a very complicated, in the sense high risk, very high risk. And she delivered in Houston Northwest, our HCA hospital. So that was good. So had a good obstetric and post-op care, postpartum for the baby as well. And she didn't. It was preterm. It was at 27 weeks. She delivered the baby, but she didn't spend any time in the hospital. So so she had.
The baby's good.
The baby's good. She brought him to the clinic. We have a picture. So it's a multidisciplinary effort. You want the dilution. So the other patients in center, she's actually our first home patient. All the in center patients, we have had like the dietitian and the social worker, like all of them involved, and then the nurses know, don't change their weight, let them gain weight, don't pull fluid, don't drop their blood pressure, make sure that, you talk to the mental health medicine and get all the reports from them. So we know what they're recommending, so, there is nothing lost in translation, because it's a very important to be coordinated with whoever is taking care of them as outpatient, because we are not in a medical center, right? So, actually only I think 10 to 15% of nephrologists are in the interdisciplinary team where they can actually, coordinate with the, mental health medicine and advanced fetal medicine care. So, all of us are kind of have to put extra input, making sure that these patients have good outcomes. All right, any questions?
Dr. Sowmya,
Yes.
sorry, I might have missed actually. Did your patient actually use next stage in home hemo?
Yes. Yeah. So that's
And
the
how
issue.
many days did you get dialysis? Like 6 days or 7 days?
So we did 6 days. We did 6 days, 4 hours.
4 hours. And what is the KT? Is it the same 2 KT over V? What was the goal for KT over V?
So we didn't target any clearance. We just wanted to make sure the BUN stays like low, like below 30. And just because we know the clearance is good. So the patient was on home hemo before, and she had good clearance before. It's just that we increased the frequency and the time. So we know she's got good clearance. We just followed her labs, BUN and creatinine, and made sure that she's, and obviously, get the iron, get all the supplements she needs, and then following up with her.
That's what I was wondering, where does that recommendation of 36 hours comes? Because 36 hours of sleep, 36 hours of rest, 36 hours of deep machine are not the same thing.
They're not the same.
Then right?
Right.
What?
The 36 hours is for intermittent, not for the nocturnal.
I know, so 36 hours
Or
of
the home.
36 hours of intermittent as in the Presenus machine is a way more GFR equivalent compared to the 6 hours with next stage. Right? So they're not equivalent, so it doesn't, right? But that's an interesting, because it depends on the modality, right? 36 hours of sleep is not the same thing as 36 hours of intermittent.
Yeah. So definitely with the intermittent you get more clearance.
Of course,
Yeah.
right? Because of the bigger blood flow and the dialysis. So.
Yeah. But they do okay, like that's the thing, like I see
Yeah, we
6 hours
also
recommended,
try to
but
do
I'm doing far less than that, and
Usually you're targeted the BUS on these patients. Right?
Yeah.
You have to get the BUN below 50 for sure.
Yeah.
That's what it is. Yes.
It's a board.
yeah,
Yeah.
so.
This honestly, you guys, fellows, this is at least 1 or 2 questions on the board.
Yes, so all of these are like extremely high yield, so I just put them all together. So that way when you guys go back, you're gonna have questions on the medications, or you're gonna have questions on, like how to differentiate, or what's normal and what's abnormal, so, so just kind of, if you just go over this 15-16 slides before your board exams, I'm sure you're gonna be able to answer.
Susceptible as a category is a very commonly asked one.
Yeah.
Switching from susceptible as a category.
Any questions you guys have?
Thank you so much.
Yeah.
Yeah, I think they have a mature requirement.
No, for us. Thank you. We will round it a little.
No, it's okay, never mind. Yeah, that's fine.
It's not funny.
Good, how are you? Yeah. They haven't given us the schedule for next month yet, right?
I don't know, I think I usually just look. I told Teresa this week, why not come Thursday, right? So I told her,
I will visit the room.
"Hey, give me a minute." Is it not in the Google Drive?
No.
I'll check it.
I'll see, I'll get it, I'll let you know.
Yeah, right.
Yeah. Oh, 10 to 13.
Yeah.
Okay. Yeah.
Is that okay?
Yes, that's.
But I'll see you
Yeah,
first.
I'm going with, and no. Oh, yeah.
I'll go next day. And then July, I think we'll go through. But August.
Your daughter is in fourth grade too, right?
10.
No, she's 10, she's
She started driving, man. Got a license.
Oh, nice, yeah. It's a little scary, but then you will be so proud later on.
So you're doing policy.
Yeah.
Who's the start?
She's still going to college. Oh, yeah. Yeah, she wants to go to be part of it. That's what do you think?
Wait for it?
Yeah.
But it's expensive.
It's expensive.
I don't know enough. I'm not in that level. Like plus all of us, like my wife, so for us, we good on that half. If it's not medicine, I don't know much about. I think she ain't right. But she wants to play.
She's gonna go big, but she doesn't know if she wants to.
So what resources are you going to be anywhere? You know, I don't know. Wake Forest is getting better than but it may be really good.
She's in private school all the way.
Yeah.
So she's good.
But I'm sure it's a good location. Wow. Okay.